Hello, my name is Ho-Young Lee and I'm from the Department of the Reconstructive Plastic Surgery at Hanyang University Hospital. Today, I'd like to introduce our review article published in the Archives of the Plastic Surgery in January this year, titled Preservation versus Structural Cranioplasty in the Treatment of the Craniosynostosis. I'm also the second author of this article. This review article proposes a new way of classifying the cranioplasty procedures by introducing the concept of the preservation cranioplasty. The corresponding author is Professor J.W. Choi from Assam Medical Center. Traditionally, conventional cranioplasty has focused on the structural remodeling, such as posterior vault remodeling and conventional fronto-orbital advancement with the bandu technique. These procedures allow immediate and predictable correction through the direct movement of the cranial bone segment and fixation with observable plate and screws. However, these operations involve wider dural dissection and more extensive osteotomies. The final growth pattern may not always match the original surgical plan as the child grows. It is presumed that when the cranial bone becomes more separated and behave like free bony segment, later growth may sometimes result in undercretion and unpredictable deformity in the setting of the ongoing bony regeneration and remodeling. That is why the distraction osteogenesis has long been considered as an alternative strategy, particularly one-piece cranioplasty has been proposed and developed over the past 20 years by Professor J.W. Choi, as shown in publications. The key point is which structures must be released to achieve the mobility. In Professor Choi's paper, Terion, the junction of the frontal bone, temporal bone, and the greater and lesser wings of sphenoid. Releasing this area can provide adequate bony mobility while also preserving the cranial base expansion and growth potential. Based on this anatomical understanding, procedures such as suturectomy, helmet molding therapy, spring-assisted cranioplasty can be grouped as preservation procedures. And this is the central idea of the preservation cranioplasty. I also prepared the related cases. This is from our paper on hemi one-piece distraction, which I presented at International Craniofacial Surgery meeting in Shanghai last year. These cases show that even in unilateral craniosynostosis, distraction of the only one side of the cranium can be effective without osteotomy on the normal side. This supports that the controlled release with the distraction, together with the native suture anatomy of the contralateral side, can still provide the meaningful expansion. This was an actual surgical case which I participated during my fellowship at Assam Medical Center. With distraction alone, we are able to observe this degree of the expansion, as well as correction of the Harlequin sign and improvement of the endocranial axis, while preserving the original structure through the preservation-based technique. As plastic surgeons, we are still in the process of understanding the natural development of the skull. Facial development is largely influenced by the cranial base. Returning to this review article, procedures such as spring-assisted cranioplasty and one-piece fronto-orbital distraction are based on preserving the native structure and relying on gradual distraction. In summary, preservation cranioplasty minimizes invasiveness by limiting osteotomies, avoiding the dural exposure, and preserving the native cranial architecture. Correction depends on the original brain growth and controlled forces such as helmet molding, springs, and gradual distraction. By contrast, structural cranioplasty uses broader osteotomies, wider mobilization and dural detachment, and immediate reshaping of the skull with fixation devices. So, the message of this article is simple. We should understand the meaning of strengths and limitation of these techniques. Based on this understanding, we should carefully choose the most appropriate surgical method for each patient and each clinical situation. Thank you very much.